All right. Thank you very much for the opportunity to speak. And I, like Rupert, thought I had 15 minutes, but maybe I don't. So I'll try to be faster. Um, we initiated this study about just over a year ago now, and there was good rationale at the time to do so. A bunch of studies had come out at that time that showed that people living with HIV were more at risk for severe COVID-19 outcomes, possibly as a result of immunosuppression or comorbidities or social determinants of health. But it was therefore important that we look at COVID-19 vaccination because it looked to be particularly important and recommended in this group. But as many of you know, there's some evidence from other infection models that HIV can blunt vaccine-induced immune responses. And a year ago, when we were initiating the study, there was very, very little data on this. So what we did is we established a prospective longitudinal observational study to look at the magnitude and durability of COVID-19 vaccine immunity in people living with HIV. And we quickly later thereafter joined forces with CTN. And what I'll show you today is the data from the Vancouver arm of CTN 328. We have already released some of our results and they are available online. And what I will talk about today is the data from our follow-up study. This is the medRxiv preprint shown here. So this was our cohort and our sampling strategy. We recruited 99 adult people living with HIV via clinics and community outreach. All were receiving antiretroviral treatment with sustained plasma viral load suppression. As controls, we had 152 adults without HIV, ranging from a wide range of ages. Majority were healthcare workers, just because we're located at a hospital. We sampled at baseline, meaning prior to the vaccine, 1 month after the first dose, and then again 1, 3, and 6 months after the second dose, and 1 month after the third dose. We're doing more sampling after this too, but what I will concentrate on today is just the data from these time points that I've shown here. Today, I'm only going to present data on antibody-based immunity, although we have ongoing studies of T-cell immunity as well. And for this study, we measured the total concentration of binding antibodies against the SARS-CoV-2 spike receptor binding domain. For the data that I showed today, we use the Roche Alexis commercial assay, as well as the mesoscale diagnostics assay. But I'll show only the Roche data today. We also looked at antibody function. There was 2 ways we did that. First, we used an assay that looks at the ability of antibodies to disrupt the SRBD interaction with ACE2. This is kind of a surrogate of viral neutralization assays. And we use the mesoscale diagnostics platform for this. And thirdly, we looked at the abilities of these antibodies to actually neutralize live virus infection. These experiments were done in our CL3 lab at SFU. And today I will show data for both the ancestral SARS-CoV-2, which is now extinct, and Omicron. I also want to briefly mention that the antibody assays that we use can also identify individuals who have had SARS-CoV-2 infection. This is because if you're vaccinated against COVID-19, this will only produce anti-S antibodies. That's because all the vaccines just encode the S antigen. But if you have both anti-N and anti-S antibodies, this means that you have also at some point had SARS-CoV-2 infection and have recovered from it. Here are the characteristics of our study population. All people living with HIV were receiving therapy. The median viral load was less than 50 copies per mil. The CD4 counts were very much preserved, but some of the nadir CD4 T cell counts were low. I'm showing the interquartile ranges here, but the nadir CD4 counts ranged as low as 10 in some individuals. The populations weren't completely perfectly matched, relatively comparable with respect to age. There were more men in the people living with HIV group, as well as more people who self-identified as white. There was also a slightly higher number of people who had at least one of the 11 health conditions listed here in red. With respect to the history of SARS-CoV-2 infection, about 10% of the cohort had already recovered from COVID-19 prior to receiving their first vaccination. And at the time of putting together this data set, we had between 10 and 20% of each group have a post-vaccination infection. We're now up to about 30%. About 40% of our whole cohort has now had SARS-CoV-2 infection at some point. There were actually some differences as well in the types of vaccines received. More people living with HIV received at least one dose of AstraZeneca. That's just because of the way the mass vaccination rollout happened. And for the third dose, there was also some differences. More people living with HIV received Moderna as opposed to the Pfizer vaccine. And there was also some differences in the timing between the doses between the groups. So we control for all of these in our multivariable analysis. Okay, so after 2 vaccine doses, what do the binding antibody profiles look like? Here is the comparison 1 month after the second dose. And here there's always 3 groups of folks on each slide: people living with HIV who are naive to COVID-19, controls who are naive to COVID-19, those are in blue, and there's this group called COVID. Those are folks who have recovered from SARS-CoV-2 infection either pre or post vaccination. Any new COVID cases before this time point are shown in red. So you see more and more people joining this group due to the presence of post vaccination infections. But as you can see here, there is a marginally lower binding antibody response after 2 doses. However, as I mentioned earlier, there are some key differences between the 2 groups. And after we adjust for all of these other variables, HIV does not remain in any way associated with binding antibody responses. Instead, what is associated with vaccine responses after 2 doses are a higher number of chronic health conditions associated with weaker responses. Having received 2 doses of AstraZeneca, also associated with weaker responses. And in contrast, a longer interval between first and second doses was associated with a stronger vaccine response. So no effect of HIV on the binding antibody levels after controlling for everything else you need to control for. Now, this is what it looks like at 1, 3, and 6 months after the second dose. And you can see in both of the naive COVID-19 naive groups, as we all know, the level of antibodies circulating in your blood wanes over the course of, after you get your second shot, antibody levels decline. That is normal. It's happening in all the groups. There is a little bit of preservation in the COVID-19 group, but that's because we have quite a few people joining this group. The other thing that you might notice is that at each of these time points, the responses in people living with HIV are, they continue to be a little bit less. However, I won't show you the actual table again. When we do, at each of these time points, when we control for all of the other variables that we need to control for, HIV does not remain independently associated with lower responses. Rather, older age, a higher number of chronic health conditions, and having received 2 doses of AstraZeneca are actually what's associated with poor responses. I'm not showing this data, but we also calculated the rate of antibody decline over time after 2 months. And after controlling for everything, there was no evidence that people living with HIV had a faster rate of antibody decline as well. What happens after 3 doses? Well, after 3 doses, doesn't matter what group you're in, you get a major boost to your antibody binding concentrations to levels that are higher than anything seen after 2 doses. So if you haven't yet, go get your booster. And as you can see, everything equalizes after 3 doses, where people living with HIV are completely equivalent. So again, third dose elicits higher antibody concentrations than those observed after the second dose. And after 3 doses, the responses in people living with HIV are equivalent to those at controls. We don't even need multivariable analysis. It's all equivalent. Okay, so here is one other function. I can't show you all the data, but I'll show you virus neutralization after 2 and 3 vaccine doses. Again, the same color scheme. And you can see that after 1 and 3 and 6 months after 2 doses, we can see that, like binding antibodies, there is this waning of the neutralization as well, no matter which group you are in. And then, the other thing that I'll compare that at each of these time points, the neutralization of people living with HIV is, equivalent to, or in some cases, ever so slightly higher, but it's never statistically significant. Always the two groups are, pretty much comparable. Okay. And 1 month after the third dose, the neutralization responses go up to levels that higher than what we've seen before. So again, go get your booster if you haven't already. And actually the neutralization seen in people living with HIV is better than that is in controls. That is likely due to the fact that more people living with HIV got Moderna as opposed to Pfizer for their booster, which is associated with higher responses. But just to summarize, vaccine-induced antibodies in people living with HIV show equivalent or higher ability to neutralize SARS-CoV-2 compared to controls at all time points after 2 and 3 doses. After 2 doses, neutralization declines over time, but the third dose brings you back to a place that actually is higher than that seen after the second dose. And if you got a third dose of Moderna, then on average, your responses were stronger than if you got a third dose of Pfizer. Okay. What about Omicron? Because, the original ancestral variant of SARS-CoV-2 is now extinct, and all we've got is various flavors of Omicron. And in this case, what I'm showing here is people living with HIV, comparison group of controls. Everyone on this slide is SARS-CoV-2 negative, and I'm showing the responses against wild type versus Omicron at 1 month after the second dose and 1 month after the third dose. And here the function that we're looking at is ACE2 displacement. So the ability of the antibodies to disrupt the interaction between SRBD and ACE. And what you want is for your results to be up here. So the first thing you can see is that these antibodies do not work nearly as well against Omicron compared to wild type. Doesn't matter who you are or what time point it is. Nevertheless, the discrepancy is a little bit less after 3 doses. So it's still not great after 3 doses, but it's better than after 2. The other important comparisons that if you compare people living with HIV and controls, there's no difference. So the vaccine responses are less effective against Omicron than the original SARS-CoV-2 variant. This is true for everybody. Nevertheless, 3 doses are still better than 2 when it comes to Omicron. The anti-Omicron responses of people living with HIV were comparable to those of controls. And we saw the same thing when we looked at anti-Omicron binding antibody levels, which I don't have time to show, and live virus neutralization of the Omicron BA1 variant, which I also don't have time to show. Okay, so in summary, people living with HIV with preserved CD4 T cell counts who are receiving suppressive therapy mount very strong antibody responses after 2 and 3 doses of COVID-19 vaccines. And I didn't have time to show it, but we didn't find any evidence that a low nadir CD4 T cell count compromised vaccine responses. So this means that just because there might have been a low CD4 count in the past, this does not necessarily compromise your immune response to vaccination, COVID-19 vaccination presently. Results also underscore the immune benefits of third doses, particularly in light of Omicron. There are some caveats to this. The results may not be generalizable to people living with HIV who are not on stable therapy or have low CD4 T cell counts. The broader CTN 328 study will hopefully answer this question. Immune response thresholds needed for protection against infection and severe disease are not completely known, particularly for Omicron, so that's a limitation. I only showed antibody data. We don't have our T cell response data ready yet. And we still need durability data after 3 doses, which is what we're working on. So thank you very much to the entire team, as well as to the CTN for the opportunity to present today. And the biggest thanks go to the participants. Without you, research would not be possible. And thank you for your attention.